So it is 7 o'clock now, and we have lots to cover. So I'll just open up this webinar, which is another in the series of AONM webinars. We're delighted to have Dr. Armin Schwarzbach with us from Armin Labs. I'll just introduce him briefly. He's going to talk today about long COVID pathogen reactivation, testing and therapeutic options. Dr. Schwarzbach is a world expert in the field of laboratory medicine and infectious disease. And he's been conducting tests in this field of Borrelia burgdorferi, co-infections and viruses for more than 20 years of his professional life. And his unparalleled expertise culminated in the creation of his own laboratory almost 10 years ago, called Armin Labs in Augsburg, Germany. And he has a large hand-picked laboratory team and has processed over 500,000 samples from patients with tick-borne disease, viruses, and other infections. So he'll tell us more today about all of that, including particularly those that can reactivate post-COVID. Please do put your questions in either the Q&A or the chat, and we'll have lots of time to cover them at the end. He'll probably talk for about 30-35 minutes. So it's over to you, Dr. Schwarzbach. Thank you very much.
Thank you very much, Gillian, for this kind introduction again. I can see here that a lot of people are from USA, from Los Angeles, Spain, Northern Ireland, England for sure. I want to say Faroe Islands. Oh, wow. This is also far away, but you see the communication is going everywhere. Thank you so very much for the invitation, Gillian, and your kind words again. I think the topic we will talk about, it's really, really important nowadays because we know that long COVID, past COVID, could be a pathogen reactivation. And I think it's pretty clear that we have in long COVID patients, as you will see later on in the slides, massive problems with reactivations, opportunistic infections. Maybe some have Lyme disease, some have co-infections, which also could be reactivated or getting worse. So one word to me, you said 500,000 tests. That's a lot we did over the last 20, 25 years. I was on the forefront the last 2 decades, just caring for Lyme and co-infections, and later on for SARS-CoV-2 and viruses and parasites, yeast and mold, mycotoxins now. I'm really proud that we have the CIP accreditation now, which allows us on the highest quality level to get samples from USA, which is a challenge, or was a challenge to get this CIP accreditation. Just very few laboratories have this in the field of tick-borne diseases, and I'm really proud that we got this high accreditation. So my agenda for today is on the first part, the pathogen reactivation. We have the DNA viruses reactivations, we have the RNA viruses reactivations, and we have bacteria reactivation. The second part will be about the testing option, and the last part, I'm also a little medical doctor, and I'm caring also for a lot of naturopathic doctors, naturopathy in the world, from Canada, all over the world, USA. I'm in contact with naturopathic clinics and doctors. So I think it's really, really important as we have a lot of viruses in the world active in the people with long COVID, and we need to do something. We come later to that. This was a study in August 2021, 22, sorry, this 1 year ago. It investigated the link between long COVID and the herpes viruses. You know, herpes viruses means it's a group of the herpes viruses. It's the herpes simplex 1, 2, 3, 4, 5, 6, 7, 8 nowadays we can diagnose. And in this paper, they did more or less the hypothesis if long COVID could be linked to these herpes viruses. And the early data that time offered a hint. And what they found that in people with long COVID, the EBV, Epstein-Barr virus, which is the typical mononucleosis virus in the beginning, in the very fresh phase of the infection, and the varicella zoster virus, which causes the chickenpox and shingles, could be reactivated. This was the first, or one of the first papers. They said it could be reactivated, and I think it was correct that time to say that, because 1 year later we can confirm that. That means that a lot of us, we have these viruses in us without coming outside, and by SARS-CoV-2 infection, by the very strong immune suppression, we got this reactivation. We name that opportunistic infections also. So we have these infections, we control them without getting symptomatic, without getting reactivation. And this is now a paradigm that we are caring now more and more about the 3 I's, we name it. It's the infection, it's the immune dysfunction, and it's inflammation. And all 3 I's, we postulated that now more and more in Irish groups and French groups with Christian Perron and Jack Lambert. We are exactly on the same track. We say always we have 3 I's. It's not just infection, it's the immune dysfunction, as I mentioned, this reactivation, this opportunistic infections. And now we come to the 80s. If you remember back, the older ones of you and myself, generation of the 50s, 60s, we had this Freddie Mercury time with this HIV infections, and that was where we learned about reactivation of viruses. So in this HIV model, we learned this opportunistic virus infections like EBV, varicella zoster, herpes simplex. They are doing or making the problems in HIV infections because the HIV virus suppresses the immune system. And after that, these opportunistic viruses are coming out. They are getting reactivated. I come later to that. So the herpes family is very important. And I think a lot of you suffered maybe from herpes on the lips, but it's not just this part of the cutaneous form. It's also internal forms of infection we are suffering from. And in a paper in June 2021, there was the first link to Epstein-Barr virus. If you go back, that was a study coming later on in August 2022. They talked about the herpes simplex virus group. So, but the first paper about was in June 2021. It was just focused on Epstein-Barr virus, EBV. And in this paper, if you remember back now, over 2 years ago, they found in 66.7% of long COVID subjects, they all were positive for EBV reactivation based on positive EBV early antigen tests. So this I will come later. We discussed that the early antigen makes a difference. So if you have an early antigen expression in your antibodies, in the IgG, maybe IgM antibodies, this is clearly an EBV reactive sign for reactivation. And in this study, these are scientists, and they found that the first time that the EBV plays really a role in this COVID-19 infection after this COVID-19. This is an example how we can diagnose on the cellular immune system EBV. There came some other papers later on. So what we do, or what we did over the last, let me say, 10 years, it's the lytic antigen. The lytic antigen means if EBV is replicating, is active, reactivated, opportunistic, reactivation, or chronic persistent, or reinfection, also possible. This means a lytic antigen is expressed again. And in this case, you see 657 stimulation of this lymphocytes in the interferon gamma release assay. So that means a clearly active infection with Epstein-Barr virus. The latent phase, latency, what does it mean, latent? I say to you easily, it's a sleeping, it's a snoring virus. Latency is allowed in you and me and other people, but not the lytic phase. Lytic phase means your body is massively producing interferon gamma. So Th1 system is overreacting against Epstein-Barr virus in this case. This is not quite normal. What is allowed for all of us? The latent phase, interferon gamma against the latent phase. This is allowed, but not against the lytic phase. Cytomegalovirus, as you know, some of you, it's a human cytomegalovirus, could also play a role in, or a driver maybe. Let us say it's a driver. This paper came March 2021, and the authors, they said that the CMV reactivation and the virus-induced immune dysfunction, we come now to the second eye, the immune dysfunction, beneath the first eye, infection, second eye, immune dysfunction, and the third eye, the inflammation, may be underestimated as a driver of immunopathogenesis in patients with severe COVID-19. So this paper, they proposed diagnosing CMV in COVID-19 patients could be well worth the effort. What does that mean with this CMV, these viruses, what they are all doing? We know that they can use our ATP intracellular, our energy. All of these viruses are using that. They're like parasites. They suck away our energy. And what does that mean? All of these viruses, if they are reactivated, they are doing fatigue. They are doing ME, you name it, myalgic encephalomyelitis maybe. So they are all doing mitochondrial pathies. So they block our energy, and so we feel tired. And I think this is one of the key symptoms of the long COVID patients too, that they all suffer from ME, fatigue syndrome. And what we can tell you, we saw this very, very early, that there was a correlation between COVID, long COVID, and the cytomegalovirus reactivation. We were working in this field before COVID with EBV, CMV, herpes simplex, because it was pretty clear that it's not just Lyme disease in these patients, so that nearly all Lyme patients suffering from chronic opportunistic reactivated infections. And what we saw in this Lyme group, that many of these, let me say 99%, they all had reactivated virus infections with EBV, with cytomegalovirus, with herpes simplex virus, with Coxsackie virus, echovirus, so HHV-6, 7, 8. So these viruses played before crisis already a role in my laboratory. It was pretty clear that also the antibiotics would not be the best option for these patients suffering from opportunistic virus infections. So that is a little history behind that. But after that, it was to me clearer that the cytomegalovirus could be reactivated by a SARS-CoV-2 infection, because SARS-CoV-2 suppresses our immune system, is doing the inflammation, and by this circle, we have this reactivation of this opportunistic infection, CMV. The problem for all of us is that we don't know what was the condition before we did this test. It could be that these patients already suffered from that infections without knowing it. So they had a little fatigue maybe, or they had a little joint arthritis or whatever, or heart problems. These viruses are also cardiotropic, so they can irritate your heart rhythm, they can inflame also your heart, they can inflame your brain, they can do pharyngitis, and massively cytomegalovirus is one of the key viruses. What I can tell you in leaky gut, in colitis, in intolerances, histamine intolerances, CMV is everywhere in the body, transported through macrophages, and in the multi-chemical sensitivity group, very, very important. Also in Spain, you will find a lot of active cytomegalovirus infections in the environmental medicine groups and also the Lyme groups for sure. So this virus is, to me, one of the most important viruses if you suffering from colitis or Crohn's disease or food intolerances and leaky gut. The herpes simplex can be also reactivated. This means the herpes simplex virus 1-2. In this case, they did a study about the herpes simplex virus 1, the reactivation in patients with SARS-CoV-2 severe pneumonia. That was also a study done in 2022, so that exactly fitting into our 3I model. SARS-CoV-2 means inflammation, immune suppression, and by that the viruses are blowing up and they are triggered, and after that you have a huge problem with this herpes simplex virus. And in August 2022, we had the next paper. Very interestingly, it showed a double infection. So because nearly all of these scientific groups, they just worked on one virus, which could be opportunistic, reactivated, CMV, herpes simplex. But this group, they worked on HHV-6 and EBV together. And they found in a cohort of 67 patients that 22% had detectable EBV and 4.5% had detectable HHV-6. And some of them had both infections. So very interestingly, chronic multiple infections, this is the key. Okay, you would say now it doesn't matter if I have this virus active or this virus active. What does it mean for my therapy? But it means you need to know what you want to treat and which virus is active. Not everybody has every virus active in the body. Now we are coming to the RNA viruses. This is one of my favorite viruses in the world. Everywhere we found this virus before crisis, before COVID crisis, and now we're checking more also in long COVID, post-COVID patients. We know that Coxsackie virus is one of the leading viruses. It's originally a gut virus. It's like it's named the enterovirus, like a poliomyelitis virus. It's can be very aggressive to your brain. Can do Alzheimer's or multiple sclerosis, myelitis, can do carditis, pericarditis, in reactivation, in also immune suppression, inflammatory phases in your life. And we know that the group B, especially group B1, and the human herpes virus 6 and parvovirus B19. Please don't forget the parvovirus B19. We don't talk about that virus today. We know that also parvovirus B19 is a really cardiotropic virus and also can inflame your joints, as an example. These viruses, please, they can circulate everywhere around your body. It depends. And all of these viruses, they can be differently aggressive in your body. It's not to be said that you get the same symptoms as your partner as it was with SARS-CoV-2 because you have different immune system. Maybe you have different inflammation in your body. Maybe you have a genetic predisposition for it. So this Coxsackie viruses, let me say, is the #1 infection in the world. It's far away before Lyme disease is coming. In the complexity, it plays a role with Lyme disease also. Let me say, if I'm doing tests for patients with ME as an example, 30% have Lyme disease, but 90% have Coxsackie virus infection. These viruses are all doing chronic fatigue. They are all doing mitochondriopathies. They're all inflame the gut, the brain, the joints, the tendons. This is like Lyme disease. So you would say, I have Lyme disease. I say to you, no, you have Coxsackie virus infection. This is a little tricky, but you need to know what to treat. Otherwise, you do wrong therapies. Otherwise, you don't treat the correct way. And a lot of you know, if we treat viruses with antibiotics in the wrong way, because we believe it's Lyme disease. I don't want to bring you away from Lyme disease or from co-infections, but if you treat the wrong way and you're stuck in this treat of this bacterial infections, you prescribe antibiotics for years and you will not come forward if you have these viruses reactivated. And what are doing antibiotics? Antibiotics are chemotherapies. They suppress your immune system. They destroy your gut, your natural immunity. 80% is destroyed. Dysbiose, you cannot repair that easily. You try to do that, but that means that you have for years problems with reactivated viruses without knowing. And we come later to the treatment part, but you need to know what to treat. I want to say to you, and Coxsackie virus, B1 is world leading virus infection. Also double infections with ectovirus. We will come to that. Now next. Ectovirus can do also, it's also gut virus like poliomyelitis virus, can be also be reactivated in COVID-19, also long COVID, can do meningitis, can make you really sick. It's a gut virus. Also really important to say the gut is inflamed, leaky gut, histamine intolerances, food intolerances, sensitivity, food sensitivities, IgG, whatever you're suffering from. The gut is so important in all of this. We come later to that. This is an example for Coxsackie virus infection. So you can see here a double infection with subtype A7 and B1. The IgA is very, very high, 1 to 100. And for A7, it's 1 to 10 titer. So this is really important to know that. Sorry to say, we didn't know that if we diagnosed these patients with long COVID, if it was existent before this infection. We name it a silent carrier, that you have this infection, but not getting symptomatic because your immune system can control that. You don't have immune deficiency syndrome developed from SARS-CoV-2 or from stressing factors or from Lyme disease. Also in this model, it fits into the SARS-CoV-2 model, HIV model. So this is a double infection with Coxsackie virus. And why to know that? You know that and you can treat. And the aim of all therapies need to be to remove the IgA production. Some are doing the secretory IgA, which is the effect of this Coxsackie and other IgA production in the gut. The Yersinia is doing, Campylobacter is doing, Ectovirus is doing. So we have this IgA expression. IgA is one of the most wonderful antibodies in the world. You know it, maybe very short half-life time, 7 to 10 days. So locally mucosal produced antibody. So very, very helpful in chronic, reactivated, reinfections, fresh infections, current infections. This is the marker for the future. Also SARS-CoV-2, we are doing a lot of SARS-CoV-2 IgA. And what we can say nowadays that a lot of boosted and infected patients with SARS-CoV-2, they have massively elevated IgG and IgA titers. I don't understand that. And IgA is so high in these patients. So it's a mucosal produced antibody. It has 2 binding arms, so it's really helpful in destroying the viruses, but it's not quite normal. It's a circulating protein in your body. 80% is circulating systemically, 20% locally. So we have the problem with this IgA, and in the final end, you have a Th2 overproduction, overreaction of Th2 if you booster, reinfection, SARS-CoV-2, or whatever infection it is. So you have a Th1, Th2 dysbalance, we name it, more Th2. What is happening? Pretty clear. You have the Th17 pathway, autoimmune disorders. And this is exactly what we see with the Cunningham panel, with also Hashimoto's, with the vasculitis part, with the anti-nuclear antibodies. All of these viruses are doing that. Also Borrelia can do that. To say that also Chlamydia can do that. A lot of pathogens can do this. Th2 overproduction, IgA, also Chlamydia can do that. And you have also a risk if you have too much IgA, you booster again. I don't want to bring you away from vaccinations, but please do your titer. Then you know how high is your titer, your IgA titer. If you have it, it's not quite normal. It's not healthy because you have a higher risk for also plasmacytoma, IgA plasmacytoma, overproduction of monoclonal. I don't want to panic you, but please think about a little this polyclonal stimulation, monoclonal stimulation. Also cancer plays a role in this, you know. Be a little careful to have too much antibodies in your body. It's okay to have some IgA, but not quite normal. Bacterial infection, pathogen reactivation, opportunistic infection. Also, as you know me, Borrelia, I'm coming from Lyme disease for sure. I'm on 𝐃𝐈𝐒𝐄𝐈𝐒 or ILADF board. I will fight still for Borrelia, for the acceptance. This is my mission. It's not mission impossible, although it's really difficult nowadays to come through with the guidelines. But what we can say, we know that increased levels of Borrelia-specific IgGs strongly correlated with the severity of a COVID-19 hospitalization. What could you mean, or what could you think about that? It's better to say. So if you have chronic Lyme, you have immune suppression, inflammation, and you have a higher risk for getting worse with SARS-CoV-2 infections. Why? Because your immune system is suppressed from Borrelia burgdorferi, especially subclasses IgG1, IgG3. So you have these problems maybe in your general immune system, the immune suppression. You have also the problem of the block from C3 to C3 activated. The complement is inhibited by some of the Borrelia subspecies, also from C4 to C4a. And as you all know, antibodies cannot work without inactivated complement. It's impossible. So you need, in the cascade of destruction of pathogens with IgM, IgA, IgG, you need the complement. And if complement is inactivated from Borrelia, also viruses can do that. We know that hepatitis C can block the pathway of C4a. So you don't have the activation of complement. The antibody against hepatitis C cannot work. And what is your immune system doing now? Your immune system is telling you after months, years, it doesn't make sense to produce antibody. Why? Because in the peripheral bloodstream, we don't need more antibody because the antibody is not used for the destruction of the pathogen because complement inhibition. And more correlations became evident also with Borrelia-specific infection. I'm not so happy with the IgGs. So as you know me, I would favorize the ELISpot studies about that, or the iSpot studies, but they did it because it's not so well known in these different groups of authors. They don't know about cellular analytics. I would be more happy if we would do studies, or they would do studies with the ELISpot and IgG in combination. And we have now more peer-reviewed studies beginning to appear about corona with Lyme. And as you know, there are different really good persons in the world fighting for that. One famous name is Richard Horowitz, and he said in many podcasts that there's a correlation of Lyme disease and reactivation and getting worse through SARS-CoV-2 infection, also Joe Brascano in statements. Okay, you would say, where is now the evidence paperwork from both of them? They didn't do that. So we need this. We need evidenced double-blind controlled studies for sure. Also, Robert Brainsfield said this is a tale of two pandemics. And what they all mean that the Lyme model, that Borrelia burgdorferi, which also can do chronic fatigue in the patients, nearly all of them have that. It's the same story with long COVID. It's the same story with SARS-CoV-2 and the opportunistic infection, the co-infections. And George Jemsek, you can also see a webinar here from A&M. He talked also about Lyme borreliosis complex and COVID-19. And Dan Kinderlehrer, I like him pretty much because he's is also on the forefront in USA. He said that most often there's an association with Bartonella and Mycoplasma with a lot of serious autoimmune problems. So we come now to this Th2 pathway, Th17 with the autoimmune dysbalances and overproductions. And there was also Rich Horowitz did a letter to the editors, and he said in this letter on the right side that a review of the literature reveals that long COVID and chronic Lyme disease share certain etiological overlapping based on published literature, including possible persistent infection, reactivation of infection, EBV, HHV-6, autoimmunity, and immune dysfunction. So we are POTS, okay, POTS, I forgot, dysautonomia and mitochondrial dysfunction. So it's always the same. We know that now. We should put it into the 3I model, or the 3I postulation. And if we follow up that, you see a lot of experts, just me or Jack Lambert talking about that, Christian Perron, also Horowitz talks about that. Also FDA is talking about inflammation and post-COVID and corona infection. So you can see a lot of people talking about that now. Also Chlamydia Mycoplasma. From the early beginning, we saw in intensive care a lot of Chlamydia Mycoplasma reactivations in the very bad cases, intensive care of SARS-CoV-2 infections. And if you remember back 3 years ago, we thought, or 2.5 years, we wondered, why are they using antibiotics? Why are they using erythromycin, rifampin, minocycline, doxycycline? Why are they using antibiotics in SARS-CoV-2 infection, intensive care? Because this first group had pulmonary problems with opportunistic reactivate Chlamydia and Mycoplasma pneumonia, the same we see in Lyme disease, the same. So it might be not Lyme disease, it could be also Chlamydia pneumonia infection or Mycoplasma. Also Guillain-Barré, you know, very, very viral and very pathogenic, active in your brain, in the joints, in your heart. And you can see also that other viruses, adenoviruses, play a role, parainfluenza 1 through 4, human metapneumovirus, rhinoviruses, enteroviruses. We're coming now to Coxsackie echovirus again. To say we don't have good tests in routine laboratories for parainfluenza. We have some tests, but not 1 to 4. To the human metapneumovirus, we don't have a good test, rhinovirus. But we have very, very good tests for Chlamydia and Mycoplasma pneumonia. We have the IgA and the ELISpot for that. And what you need to know, what you need to learn, take away message, that Chlamydia pneumonia also lives in the mucosal membranes. I talked to you about the Coxsackie echovirus, cytomegalovirus living there, Epstein-Barr virus living there, Herpes simplex virus living there. They all live in the mucosal membranes, and they can also act as a reservoir of chronic infection. And in this slide on the left side, you can see that Chlamydia pneumonia can do a lot of symptoms in us, a lot of syndromes, Alzheimer's disease, multiple sclerosis, schizophrenia, atherosclerosis. Very, very important to know that it can also do heart attacks and strokes, these Chlamydia pneumonia infection. Lung cancer, it's a cancer pathogen, biliary cirrhosis, liver problems, diabetes, arthritis, and Behçet's disease. Also chronic fatigue is described. There's a lot of, and food intolerances. There are also teaching books, if you're interested, from Professor Stratton. He did a lot of work in that. There's a huge group also in America, Chlamydia pneumonia infections. And also what we know, I think on the right side, a very important sentence is that there's evidence that Chlamydia pneumonia induce oxidative stress. We come now to the oxidative stress, may contribute to endothelial dysfunction by decreasing the NOS expression and the oxide synthesis in endothelial cells. So, and what we also know, that Chlamydia pneumonia is able to survive in monocytes and macrophages. Macrophages, they play such an important role, not just for Lyme disease, for Borrelia burgdorferi, also for viruses. Every pathogen, or a lot of pathogens, they survive in the monocytes and macrophages, and then they can move everywhere in our body, where they like, where they want, into the brain, into the heart, tissue, into the joints, into the arterial system, everywhere. So these are the reservoirs. And also maybe go back, Chlamydia pneumonia can also do persister forms, can do biofilms, which is a huge chapter in the future. The biofilm breakers, how to destroy the biofilms, will be a chapter for the future. Not the antibiotics. The groups are working more on the biofilm destruction now. Because what is a biofilm? Biofilm, you would say it's protection. It's also communications and so sensum coring. It's a communication, a chatting area. Sensum coring, it's named. I think it's a difficult word, but they chat with each other. They communicate, they replicate. They go into restriction. They go into sleep mode. They can get really resistant. No antibiotics can work in this, like Borrelia can do that in persister forms, intracellular, not to reach aberrant form. And if you go to the horses and the dogs, they have massive problems with it. And the vets are much better than myself, the human doctors. They know much more about Chlamydia pneumonia infection, how to diagnose and how to treat. So Mycoplasma also, it populates the mucous membrane systems, and it can be everywhere in the small intestine, in the entire respiratory system. So a lot of biofilm slime is coming out sometimes of this patient, some cough, sinusitis, teeth problems, necos, and so it can also survive or be in the vagina, fallopian tubes, and uterus. Also, the question of the sexual transmission could be there, and also in the vesicles of the brain, can do the white spots of multiple sclerosis, as an example, and the eyes and synovial tissues in the joints. And most of these mycoplasma symptoms come from infection and damage of the cilia. And the mycoplasma use the inflammation. We come to this third eye inflammatory processes to make the epithelial endothelial structures more porous, penetrating deeper, damage your tissue, and we cannot repair the tissue. We cannot repair this. We can stop this inflammation. We can stop maybe the penetration, but to repair is a different thing of this mucosal system. Sometimes we can, if we not coming too late, sometimes not. Which is my specialty. We have developed some years ago, no, 1 year ago, I don't know, I don't remember, post-COVID trial reactivation panel, a basic for cheaper money, and an advanced panel. As you can see here, it's the 𝐕𝐈𝐃𝐈𝐒, it's the CMV 𝐈𝐒, varicella zoster IgA. This is better sensitivity for varicella zoster, and the Coxsackie. This is a little panel, and if you will order it in long COVID, you will surely find out what you're suffering from. Not everybody's active in every infection. Every patient has an individual profile of active infection. As myself, I never had herpes simplex 1-2 infection. I'm completely negative, but my problem always, my whole life, is Coxsackie virus infection coming from the gut, this herp angina. I never had varicella. I was vaccinated varicella zoster infection. I never had cytomegalovirus infection. So, but it's different from patient to patient. Therefore, it makes more sense to go a little broader, do the 𝐕𝐈𝐃𝐈𝐒, CMV 𝐈𝐒, varicella zoster antibodies, Coxsackie virus antibodies, herpes simplex virus antibodies, 𝐕𝐈𝐒, HHV-6, Chlamydia, and Mycoplasma pneumonia. And I would say if you do such a panel, you will find 90% out from this long COVID patients active for one or more of these infections. 2 or 3 you will find. I think it's the average of these patients with long post-COVID. We developed also electronic checklists, which can help you to decide which co-infection to test in post-COVID. It's a automized system, and you will see a ranking. It's named the artificial intelligence system we developed here, which will play a role in the future in whole medicine also. So from teaching books, you can find these symptoms for different infections. And this is the algorithm behind this post-COVID checklist for different infections. We did it 2.5 years ago because it was pretty clear that we have a lot of these reactivations in this post-COVID group, which came up shortly after the first wave of COVID infections. To the checklist, it's free of any cost. It costs nothing. And if you don't have any symptoms on it, okay, you don't need to be tested for some of these infections. Why? You're symptom free, you don't have that. But if you have some or more of this patient of these symptoms, you as a patient, you will find yourself in some of this ranking of these infections. A&M will help you in the test selection for if you don't want to do the test panels. If you say, okay, I just want to do 1 test or 2 tests for my pocket reasons, and then maybe if you don't find anything, I do in this ranking. Here's a ranking 1, 2, 3. So the more symptoms you have for an infection, the higher is the probability that you suffer in reality from this infection. And this is the predictive value. The artificial intelligence is part of the prediction we are doing statistically, mathematically. So I think this really way of the future, how to diagnose infections clinically, because you can be sure a lot of doctors don't know that. They don't know the symptoms of these infections. A full-time job for professionals doing nothing else than caring which symptom is described in which infection. Now, therapeutic options. To know that we have now evidence that the S1 protein can persist up to 15 months or longer in long COVID patients. So this is the S protein. This is exactly what we did the IgG test. This is the expression of that. So that means SARS-CoV-2 is dead in your body. It's not living. But the spike protein is somewhere in your gut, in your mucosa. It's somewhere in your heart. It's somewhere in your brain, and you still produce immunological cellular immune reactions. Therefore, we have the 𝐈-spot, it's named, the SARS-CoV-2 𝐈-spot, or you find humoral, that means antibody immune reactions. So we find more antibody immune reactions, I would say, than in the long COVID, because you lose Th1 system, cellular immune reaction, and you switch to the antibodies. This is also pretty clear now. The question is what I mentioned already, biofilms, and so we need to do something against the spike protein. And as I mentioned before, we know these biofilm breakers, and nattokinase is one of these. We also use in Lyme disease. You need to drink 3 liters water without gas, otherwise it's not working. We have also in treatment option the dandelion extract, Nigella sativa, and also we have the autophagy and the mitophagy in this. That what is inflammation? If your gut is inflamed, you have an inflammation in your whole body for sure, because a leaky gut means that a lot of toxins coming into your venous, also the liver system and the lymphatic system especially. Oh, I forgot to mention, all of these viruses are lymphotropic. So they block your lymphatic system. You cannot detox. You have a problem with the viruses because they are lymphotropic. You know, they like your lymphatic system, and you cannot detox in the liver and the spleen, in the whole lymphatic, in the lymph nodes. And some of the patients, they have swollen lymph nodes from time to time. So the lymph node status is very important to ask, and maybe you taste some of your patients in the neck if they have it. Some of them have it coming and going. It's a very important question. Did you have swollen lymph nodes or not? They cannot detox so easily. And some need lymphatic drainage. I think that's the right expression. So you need a drainage that to bring it back to a flow, you know, that makes sense. what I want to say, coming back, very, very important is your gut. As I mentioned, your gut is, if it's inflamed with viruses, CMV, Coxsackie, echovirus in the, or Yersinia campylobacter in the mucosa, you have a problem in the mucosa, and you have still maybe a wrong diet or the wrong nutrition, and you need to do a good nutrition. So avoid, as an example, avoid the sugar, avoid alcohol, avoid the gluten, avoid lactose, avoid pasta, pizza, noodles, avoid bread, avoid meat completely. So you know that you need to follow the rules, otherwise you will not get healthy. And sometimes you need also to clean your gut, because your gut is so full of toxins, you cannot imagine that. Also maybe of parasites in your gut. So or you had parasites, but be careful with your gut, and switch your nutrition completely, please. Otherwise, you will not get health. If your gut is inflamed, your body is inflamed, you have these viruses, you have parasites, you have some other enterobacteria in your gut, maybe, please be careful for your gut. Do a lot of exercises. We know that. And where I have also learned a little my own history with my own gut virus infection, what I've used also a lot of herbs, herbal therapies from nature. There was a sentence, we cannot do anything against the viruses. And I said, for last 7-8 years, we need to do something against the viruses. Why should we give up? And then I came to this wonderful book from Stephen Puhner. And Stephen Puhner, he described the herbal antivirals. And then I bought this book and I said, wow, there's a lot of literature behind that. I did not know that about spermidine, resveratrol, curcumin, berberine, quercetin. So you have a lot of these herbal which can help us. You can try that out. And I know in a lot of therapies, they play a very, very important role also to support the Th1 immune system, because as I mentioned before, if you have chronic reactivated infections, you switch away from Th1 to Th2 system, and then you have overproduction of antibodies, and then it's difficult to switch back to Th1, so we need Th1 support, and the herbs can. One very efficient, let me name virostatic or virus remedy, what I'm taking myself, I'm taking L-lysine at the moment, 1 gram in the morning and 1 gram in the evening, 1000 milligram it is. So these are big capsules. Monolaurin is also a very good alternative, and we know that bioactive monolaurin can be antimicrobial to improve the immune system and against COVID-19. Whatever you can do, whatever you can tolerate, this is a good option, but also I could tell you from my own and other patients' experiences. And we have also these pleomorphic forms, which I mentioned, Chlamydia and Borrelia, the round bodies or the cyst forms. And also there's now ongoing research on that as an example, chlorella could help, nettle extract, bilberry extract, cranberry extract, lingonberry fruit powder, artichokes are good. If you live in Italy, the artichoke heart, the hearts, if you can get this, it's wonderful, it's healthy, we know that. It's a natural way maybe to do something for your immune system, maybe to improve your immune system, maybe you do indirectly something against the virus, but it's pretty clear if you support your immune system by some of these changes of nutrition or anti-inflammatory diet or some of these remedies you add to this, you get a better immune system. What happens? Your immune system is stronger to control the viruses, to bring them back under control. If you don't work on the inflammation and on your immune dysfunction, you will lose that. It's not to say, oh, I buy now some 𝐓𝐇𝐈𝐒 on the pharmacy, or ganciclovir, valaciclovir, whatever. These are virostatics. They can help you temporarily, but they will not support the immune system so much. They for a longer time, and they have risk and they have side effects. So herpes, especially Epstein-Barr virus, EBV, cytomegalovirus, varicella zoster virus, we know that licorice could be also one option. to try it out against EBV. I don't want to say you can cure, you can heal. We need studies, we need evidence, more and more about that for sure. But if it's for you helpful, also the Enterovirus paniculata can help against EBV, CMV, herpes simplex. I don't think that these herpes are especially for just EBV. They help in all of these viruses, also Mycoplasma virus for sure. Also the skull cap, helpful against Coxsackie virus. One of my options also Tacuna, Houtunia, also some herbs. The Dandelion can be helpful against the SARS-CoV-2 spike protein. Artemisia annua. It's a complicated thing in Europe now, European Union, because it's not allowed a novel food truck to distribute it or to bring it in capsula. So, but it's maybe you use a tea or something like that, Artemisia annua tea, which can help you also against herpes simplex viruses, EBV viruses. Try it simply out. It costs not so much, and you cannot get a use from it. Also, other herbal and nutraceutical remedies, black seed oil as an example against cytomegalovirus, quercetin, zinc. Magnesium is not coming in that. Magnesium should be also used sometimes. Additionally, curcumin, okay, we mentioned already before. Cistus, it's a plant we also used in Lyme disease years ago. Try it out. There's a whole bunch of options. Lysine, now it's coming. Oh, that's good. Entire family, but it's also against Coxsackie enteroviruses for sure. Support for immunity, natural killer cell activity, glutathione, liposomal. Okay, if you can get this liposomal, and also enzymatically modified rice bran. And there was development of a company which was named the Phytobox company. I know that AONM is very active in this field also to offer something in England. They're very well established in Germany and some other countries. This is a combination of different products. It's not to say now I use some of these and I get healthy within 1 day or 2 days. I would say the average is 3 to 6 to 9 months. But if it's successful, it helps you do it. If it's not helpful, do it 1, 2, 3 months maximum and then stop it. It's a waste of money. Then switch your concepts, rethink about that. And also there's some evidence about that. AONM, Professor Gilbert is working on that. Phytochemicals for Lyme disease, as you know it may be. And in the end, I want to invite you heartily, so some of you therapists, especially naturopaths, naturopathic doctor, medical doctors. We do a conference here in Munich. We have now 150 registered people, so it's quickly sold out, I think so. If you can find a place here, there are very, very good speakers coming there in this field for the transfer factors, what you can do for Th1, Th2 immune system, what can you do against the biofilms. This is very, very interesting. I think also the conference, speakers from Canada coming, from England, from Belgium, from Germany. So we have a whole a good list of speakers. Yeah, we have also some speakers who will look outside the box and not inside the box. So the traditional school medicine, maybe sometimes, but we need to discuss that. We need to come forward, and you're heartily invited. And thank you very much for your attendance. And I'm waiting now for a lot of questions and a lot of discussion.
Thank you so much, Armin. That was fascinating, amazing amount of information. Actually, you've been speaking, you probably didn't realize it, for over 50 minutes. So we don't have a massive amount of time. So I'll ask you in a moment whether we have an alternative option for that. But let's start with the questions that we have. So I'll just go through them sequentially. And quite a few people asked about let me just get onto here. One patient is saying that he was put onto antibiotics and he got H. pylori right afterwards and has had problems ever since. And many actually write about the problems they've had with antibiotics in this kind of situation. Is that something you encounter a lot because of the high viral load?
So he got the H. pylori reactivation, or
right after being put on antibiotics.
yeah, no, normally we use in H. pylori treatment antibiotics, but if it was the wrong antibiotic, it would not have worked. Maybe it was the wrong antibiotic suppressing his immune system, and H. pylori can be also reactivated if you use the wrong antibiotics. But he didn't know that maybe before that it was a problem in his body. And some H. pylori are multi-resistant against antibiotics, also a problem nowadays. They developed resistances, but antibiotics are used also against maybe should go to a gastroenterologist for a recheck and biopsy or whatever, and then to know how to treat this H. pylori infection.
Yeah. Another patient says that after swimming, she picked up something that was treated with amoxicillin, and that seemed to bring on her long COVID symptoms.
Yes, yes, exactly. Antibiotics are immune suppressive, and they destroy your gut, your natural immunity. So they are chemotherapies per definition. So you suppress the immune system. Leukopenia is falling, and the leukopenia and the CD3 cells going down by that. And then you have the problem of opportunistic, and she should check for viruses for sure. Yes.
Yeah, yeah. One question here, which is quite a common question, is whether the 𝐕𝐈 test for Borrelia is accepted by the NHS. And of course, I'll just mention, you know this though, that one can't sort of put all the NHS GPs and doctors into one bucket. You know, many of them do have broader experience, contact with infectious diseases doctors in other countries, and have gone to CPD, that that there's also more understanding of T-cell testing, cellular response testing in the UK now than there was. But it can be a problem, can't it? Simply because the test is not done in this country, even though
yes.
It should be accepted because it is UCAS accredited.
There's a little movement when in England you had this company who produced the 𝐕𝐈𝐃𝐈𝐒
Oxford Immunotech.
Oxford Immunotech, exactly. And I know that this company is very interested also in Borrelia test for that. So they know that. I think they developed something in the background, because it's pretty clear that you cannot avoid the cellular tests. It's pretty clear. In tuberculosis, you cannot avoid as well. In transplantation medicine, you cannot avoid this. The acceptance is a different thing. They don't accept Lyme disease for the patient telling the story with the tick bites, and so they don't accept the test. They say it's false positive. But my experience is that I think it's in most cases maybe not so active as what we expected. Therefore, we do the 𝐈 now, where the interleukin 2, we can see it's more a past infection. But be careful, not everything is Lyme disease. Also, need not to overpace the Lyme discussion everywhere. Check also for other opportunistic infections if you suffer from that. I just can tell that to you.
Yeah, several patient attendees have asked, why do you think Coxsackie is so widespread? Could it be from medical interventions or from infected water supplies?
Where's Coxsackie coming from, Gillian? Yeah. Where's it coming from? Yeah. Coxsackie, where is it? I want to tell you, it's a little village in the state of New York. I drove my car to Albany, and it's they were the first cases. And interestingly, it was also on the ticks. In Texas, there were people infected from Coxsackie virus through a tick bite in the 90s. Why is it so very common? Why is it so very common? I don't know myself, but what I can tell you, it's number one infection. Simply, it's a gut virus. Maybe our immunity is so bad, our nutrition is so bad now for our gut. I cannot tell you why is it number one. Poliomyelitis, why did they do the vaccination against poliomyelitis? Because it was a massive worldwide problem coming back now from East Europe more and more.
It's also
poliomyelitis, also gut virus.
It's the same family, isn't it?
Yes, same family.
What does a high IgG for Coxsackie tell you if the IgA is normal? Does that still warrant potential treatment?
Yes, that's also very interesting. We do this discussion. It could, a high IgG could suppress in very, very high dimensions an IgA, IgM production. So this clone is so massively, but this is a high risk also for paraproteinemia. So you need to do a protein electrophoresis, the immune globulins quantification. If titers are coming so high, it's not good. You need to do a follow-up, maybe 2, 3, 4 weeks later, you know if there's a movement in it. The half-life time of IgG, you know, is 2 or 3 weeks. For IgA, 7 to 10 days. So it's a dynamic process. One titer in laboratory medicine means no titer for IgG. So you always need a follow-up if you're not pretty clear if the titer is too high.
Yeah, just one follow-up question from the Q&A that links to that, and then I'll go to a question that came in earlier. Have you been able to correlate treatment interventions for viruses to reductions in stimulation in subsequent testing? In other words, do you actually see the difference in testing?
What we can tell you, we have this Herxheimer reaction or Herxheimer-like reactions in Lyme disease, and we see that exactly when we use, let me say, 1 drop from Tacuna or Tunia, 1 drop, people exploding, get massive reactivation. And we see that also in the test in the first phase. That means if we discuss it now with Professor Schietzl, he's a professor, we discuss it very often with this Coxsackie and other viruses. EBV, he said to me, yes, if I hit them in the beginning, there's an explosion of the virus, patient getting very worse. They cannot tolerate the treatment. So why is this? I think there's a massive antigenity in your blood, a massive problem of detoxification in the lymphatic system, a massive problem of the biofilms, of the sludge, the coagulopathies. Maybe I mentioned also what is really, really helpful for long COVID is the HELP apheresis. We have so many coagulation problems in these patients with long COVID. It's clear all of these infections are doing sludge. They have cold hands.
Very specific to Germany, isn't it? We don't have that here.
No, it's also in South Africa. There's a new group coming. We need this apheresis. For some, it's expensive, I know that, but for some, it's really, really helpful tool. The apheresis, not the general, not this inospherase, whatever they're doing. It's a special filter. I'm not the expert for that. Nephrologists should do that. But this apheresis could be also, because the coagulation means also a problem to us, you know.
Yeah,
so
isn't it, to COVID, without going into great detail?
I forgot to mention that.
Very much so. We're running out of time a little bit because of you having so brilliantly spoken for longer than we were expecting. So could I just ask, before I ask this other question I have here, whether you might be prepared to give us another session like this, but just for questions, all the questions that have come in specifically relating to this. Could we call you? Because we sometimes promise this and then we don't quite get round to it. Could we call you right afterwards and book a time? Because all of these questions we will save and then ask you. The fascinating questions have come in, but we don't need another hour to ask them all. Would that be okay?
I would like that. Interdisciplinary round table discussion. Okay, I fulfill my part. Maybe you do a therapist on that round table.
Yeah.
So that
would be fantastic.
A therapist on my side, a laboratory doctor. So from my immunology perspective, and then we could present cases. Also, patients come in.
That's a brilliant idea.
Doctors come in and present cases. This is living medicine. You know, this what I did is presentation studies. Okay, this is boring. Maybe sometimes this is not so, but you need a baseline. So a follow-up makes sense.
Yeah, we'll do that then. Thank you. And we promise everybody we really will do that. I know we sometimes say we will and then don't quite get round to it, but that's a promise. So could you please speak to the role of complement pathway labs for diagnosis indicators? This attendee noted that you had previously mentioned C3 in sleuthing viral loads, and she'd like to know more about its significance.
This is a huge problem of the logistics and the pre-analytics, because the complement is, the molecular weight is a little one. So you need to freeze that. And the best is you go to a laboratory nearby, take the blood, freeze it, the plasma or the serum, what they need, and then do the test. It's the same with little hormones, freeze it. Homocysteine, also a problem. The time, the temperature, you need to freeze that. Otherwise, it's damaged. The result is false negative. It's simply too low and maybe it's higher, so wrong conclusions. The pre-analytics, you cannot send to me C3A, C4A. This is a test for a bedside laboratory test, I would say. You go to the laboratory, take the blood, do it in front of the laboratory. Laboratory will centrifuge immediately, freeze it, -20, and do the test with you. And then you have the best results in the world.
Yeah. And D-dimers and troponin and fibrinogen we've sometimes asked for you, and you've very rightly said that has to be done
the same.
Immediately. Yeah. Okay. Well, I'm conscious of everyone's time. I would like to just say a huge thank you. And can we call you right afterwards and book you in for the follow-up with all of these hundreds of questions that have come in? Is that all right?
Thank you so
and
very
also
much.
say a big thank you.
We see you again in this group.
Everybody is expressing their huge appreciation to you as well. We're just mindful of everyone's time and
thank you very much.
Just 1 hour. Just to say very briefly that we do have another webinar that is planned on the 26th of September at 7 o'clock, and that's with Dr. Robert Verkerk and Melanie Aldridge presenting their book Reset Eating, which is relatively new, a tremendous book called Taking Control of Your Health by Turning Your Food into Powerful Medicine. So they'll be making lots of links to this presentation and others as well. So, Armin, I hope that everyone will consider joining your Chronic Pathologies conference, even if it has to be virtually. I found out just recently that it's only €50 to sign up for the 3 days if you do that virtually, which is incredible. It's very reasonable, isn't it?
I'm not the organizer, so ask Marcus.
No, I asked the organizer, and actually I was stunned by how reasonable it is, and presumably one gets the recordings as well. So for 3 days of conferencing, that's amazing, really.
I think it's Oktoberfest time, so you could go to Munich.
Yeah, but anybody who comes, obviously, that would be preferable, wouldn't it? Celebrate with us. You'll be playing from the stage as well, your music. You did promise that earlier.
Dieter Klingert is playing guitar again.
And so he will too, yes. Yeah. Okay. So everybody, thank you very much for being there, and look forward to seeing you again, hopefully in a couple of weeks' time when we have our question session. Thank you.
Thank you. Bye-bye.
Bye. Bye.